So that is your board certification review courses, little about prompt review academy, and we'll be talking about skin. So one of the things you can be asked is a Mongolian spot. You can see the diagram may not be so clear, but remember this is just for teaching purposes. You can always study more, but in the exam they can give you a clinical presentation of a child with a bluish green to gray blue markers or patches located predominantly on the lumbosacral area and posterior trunk. So it's always at the posterior trunk at the back or the lumbar sacra towards the sacral area. So another thing you need to remember that this is more common in infants with darker skin pigmentation, including Asia, Africa, Hispanic, Native American descent. It is a benign condition, meaning you don't have to do anything. It usually fades away gradually during childhood, or it can completely disappear by adolescence. So, what is the cause of this Mongolian spot? Is from the trapping of melanocytes in the dermis during the embryonic migration. But nobody's asking you this. The only thing you need to know is first of all, is a congenital mark, is a birthmark. Okay, Mongolian spot. You can see it here. The diagram is not um too well. And another thing is it is important to document this to avoid confusion in the future with bruising or potential allegation of child abuse. So it's good to document it when you see it in a child because it's a birthmark. And another important thing is to educate the parents that it will resolve on its own. It will fade away gradually. So know that it is more common in darker skin pigmentation, and when they describe it, remember the location. The location is usually lumbar area, lumbar sacra, lumbar and sacrum. So lumbar sacra and posterior trunk. So that is your Mongolian spot. And know the description: bluish green to grayish blue markers. So anytime they describe something like this at the posterior trunk, is always Mongolian spot. Another one is mumps. Mumps, mumps. Mum, you can see it in exam, and you should always know that it it is what? Bilateral para tide and paratide gland swelling. So know this word because they can ask you what gland is swollen. Is a parotid gland. Okay, it's a parotid gland, and this can also cause infertility in male if it's not taken care of. So that is what you need to know. It's a cause. It happens at the parotid gland. The child will have swelling, bilateral swelling, and if it's not taken care of when the child is younger, it can lead to, of course, infertility in the future in the male. So this is after stomatitis. After stomatitis is under ear, nose, throat. But the only thing you need to see, you can see this picture because it's a picture. We are talking about skin. But in ENT, they can describe this for you, and it's a painful shallow ulcer with a with white or yellow center. So this is the one we say that we always treat with um, magic mouthwash. So that is after stomatitis. So magic mouthwash. So you can see it can be worsened by eating acidic or spicy food. That can make it worse. but you can see the diagram is like shallow, painful um, ulcers inside the mouth. You can be asked about herpes simplex virus. Herpes simplex virus. So what you need to remember here is that we have, which all these things are all connected. So I will try to connect it as much as possible because this is also STD. So under STD, we have herpes simplex virus, and we say that it can cause three herpes situation, which is herpes one. Herpes one is your oral herpes. Then you have the herpes two, which is the genital. Then we have the hepatic whitlow, the one that happens in the finger. Okay, but always know the treatment for herpes, which is your antiviral. Example is acyclovir. And don't forget the prodrome. Prodrome is what, this comes. So when you ask the patient, do you experience any of these symptoms when this appears? Because it appears like a painful cluster vesicles on the erythematous basis. So which is the oral herpes. You will see it in that erythematous, with erythematous base. So you ask the patient, do you have tingling, burning, itching? And I always remember it as what? BIT, beat. Do you have burning, itching, and tingling? That is the prodrome. That is what accompanies that herpes, the oral herpes. Okay, BIT, burning, itching, tingling. Then we have a condition that is high yield in the exam, and that is the keratosis spiralis. So this keratosis spiralis is also known as a condition that is caused by keratin buildup. Okay, it's caused, so it's like if you have an idea of um chicken bumps, like somebody that have goose bump, but it's always known as what? Skin. Is a dry skin, and that is why the first line of treatment for the exam is usually moisturizer. Moisturizer. So moisturizing agent, because it's always like a dry skin. Okay, so it may appear like a sandpaper texture rash, but the texture. But if you always remember, like when you are feeling cold, you have your body shivering, and you see like all those goosebump. Those goosebump is what it is. Sometimes they call it like a chicken skin. So that is your ketoro. So the way the word chicken skin, but always remember it as a goose bump. So, but the only thing you are looking for here is that the treatment is moisturizer. So, because it looks like a dry skin, so you give them moisturizing agent. Then we have empatigo. Empatigo is high yield in the exam. And under empatigo, we have the two types. The two types of impetigo, which is the bullous and non-bullous. So bullous means the one with blister, and the one that is non-bullous is the one without blister. Okay, so and the treatments are all different. If it is a bullous impetigo, which is the one with blister, the treatment is usually KCD. If you follow my previous videos, you will see it. So the treatment is, if it's a non-bullous, that is this thing here. So if it's bullous, that is the one with with blister. The treatment is what? KCD. So what is care CD? Care is cefalexin, which is carefless. C is clindamycin, and D is dicloxacillin. So this is it for bullous, the one that has blister. Okay, but if it doesn't have blister, which is the non-bullous type, the treatment is Bactroban, which is also known as Muciprin ointment. So what is high yield here? You must know the treatment. Are they asking you about the bullous or the non-bullous? Another thing that is high yield here is the definition. What is the definition? It is a honey crusted lesion. Honey crusted lesion. Anytime you hear about honey crusted lesion, that is impetigo. And it is primarily caused by Streptococcus pyogenes and Staphylococcus aureus. So, but know the definition, which is your honey crusted lesion. Know the treatment. One is bullous. Bullous is with blister, and non-bullous is without blister. So we have your pityriasis rosea. What is pityriasis rosea? That is the Christmas tree pattern. Christmas tree pattern rash. So it's a type of rash that looks like the Christmas tree. So you can always call it Herald patch, Christmas tree pattern, pityriasis rosea. Okay, and it's always self-limiting. There is no cure. The only time you provide cure is if it's getting worse. Then they can do like antihistamine for the itching and topical steroid for severe cases. But outside that, it's self-limiting. So in the exam, you say it's self-limiting condition. And anytime you hear about patient presents with Herald patch or presents with a type of rash, a Christmas tree pattern, that Christmas tree pattern is your pityriasis rosea. Then we have our Rocky Mountain spotted fever, which I always say to remember with RMSF, as the name implies, which is your Rocky Mountain, Rocky Mountain spotted fever. So R is caused by the tick bite. What is the tick? It is caused by Rickettsia rickettsii. That is what it's caused by. Rickettsia. They can ask you about the tick for Rocky Mountain. That is Rickettsia rickettsii. So that is your R. That is how I remember. Then M is your maculopapular rash. This person is going to present with so M is your maculopapular rash. It starts with the rash on the ankle, on the feet, on the soles, like it comes in the palms, the wrists, the ankles. It spreads to the soles of the feet. So remember maculopapular rash. The R is the Rickettsia rickettsii, which is the tick. The M is the maculopapular rash. The S is those symptoms. Sorry, the S is that it's happening from patient coming from the southern part. So that is what we have, southern central. So for example, patient is coming from North Carolina. Some people get it mixed up and think that North Carolina is a northern part. It's usually southern part. That is your S. Then F is the flu-like symptoms. So patient is going to present with fever, headache, myalgia, malaise. So all those flu-like symptoms that they have. So what is the treatment for Rocky Mountain spotted fever? The treatment is usually doxycycline. And remember, doxycycline is for all ages. For all ages, even if that they are young. Doxycycline is for all ages. Okay, doxycycline is for all ages. Then we have the Lyme's disease. Lyme disease is another one that is caused by a tick. And what is the tick called? Bure, Burali bugedefari. Bulari bugedefari. So, like I said, sometimes they can ask you the names. So, the way you have Rickettsia rickettsii for Rocky Mountain, that is the same. You have Burari bugedefari for Bush eye and Lyme disease. It has a red rash, central clearing, and the bull's eye lesion. This is a buzzword. Whenever a patient presents with a rash, that is bull's eye lesion. Bull's eye lesion. Okay, bull's eye lesion. Another, so it's always, it begins as a small red marco, which is a small red rash. And before you know it, they will have a central clearing, and then they will have a bull's eye lesion. Okay. What is the treatment here? The treatment is doxycycline, but if the person is less than 8 years old or the person is pregnant, and that is how we differentiate it from Rocky Mountain. For this one, if the person is less than 8 years old, we don't give them doxycycline, we give them amoxicillin. So know the difference. When you compare these two together, Rocky Mountain is caused by the tick, and the tick is Rickettsia rickettsii. But the one for Lyme disease is Burali bogedefari. And Burali bogedefari, they start with a red rash, central clearing, and a bull's eye lesion. So that is the buzzword, bull's eye. But the one for Rocky Mountain, we say that it starts with a maculopapular rash, like a rash you are going to see on the wrist, on the ankle, then it's going to spread to the palms and to the soles of the feet. So these are some of the things we have covered already. We covered the Lyme disease, just a little recap. If they ask you, a patient presents with honey crusted lesion, what is that? The answer is impetigo. If they ask you, a patient presents with a chicken skin appearance, upper arms and thigh, the answer is keratosis spiralis. And I said the treatment is moisturizer. We have talked about the herpes, and I said that with herpes we have is grouped vesicle, and we say that with herpes is with herpes we have two types of herpes, which is the three types: the oral, which is herpes 1, then the herpes 2, which is the genital, and the third one is hepatic whitlow. And I mentioned the prodrome. And what is the prodrome? The things that accompanies it. These are the things you ask the patient, did you see any of these? Or do you have any of these symptoms? And I use the mnemonic BEAT, which is burning, itching, and tingling. And for bull's eye lesion, that is your Lyme disease. And we say that if the person is less than 8 years old or the person is pregnant, they are going to use amoxicillin. But for Rocky Mountain spotted fever, everybody gets doxycycline. So this is just a summary of what we just covered. Okay. Then we have other ones. So this was the herpes I was talking about. It the herpes, oral herpes, and when it's like this, we say that this patient you are going to, and if you look at it, we say it is a cluster vesicle. So anytime you hear vesicle, clustered vesicle on erythematous, erythematous is red, Whenever we said erythematous is red, you can see the mouth is a little bit red. Okay, and the treatment is acyclovir. Then we have another condition. These are common skin conditions on the oral lesions, the one you can find in the mouth. Another one was stomatitis, the one we covered already. Stomatitis that we use the magic mouthwash. Then another important one is a geographic tongue. So geographic tongue is like it's caused by like spicy food, and is a benign condition. Like it looks like somebody that ate something really really hot, and if you see it, it looks like a map-like pattern in the mouth. So you can look up the picture, geographic tongue. Another things you can see inside the mouth is oral candida and the leukoplakia. So for oral candida, it presents as a white patches inside the mouth that can be scraped off. That is the buzzword. It can be scraped off. But the one for leukoplakia, it cannot be scraped off. And you have to know the difference, because the one for oral candida, it can be scraped off, but the one for leukoplakia, it cannot be scraped off. And always remember all this information. You can always see it. I'm just for teaching purposes. So this is your leukoplakia. This is your leukoplakia. This is your leukoplakia. So if you look at the picture of the leukoplakia, you see that leukoplakia, white patches that cannot be scraped off. That is the buzzword. It cannot be scraped off, and it needs referral to a dentist, as infection can be detrimental to the enamel, and it can always be seen in HIV patients, precancerous, and it requires possible biopsy. So very important, very important. So but we have the candida, which is also, when you look at the candida, you see it's white, but in candida it can always be scraped off. It might not be the best picture, but it's just an idea. Every so so you can see these two. So sometimes it's always good to just use the pictures when you are studying skin, to have an idea. Okay, what are they talking about? And with the pictures, it helps you to remember what you're studying. And the one for the geographic tongue, like we said, in geographic tongue, it looked like somebody that ate something very hot. So this is the picture of the geographic tongue. And we say that geographic tongue, it's what? The geographic tongue is caused by spicy food and presents with distinctive map-like pattern on the tongue surface. This condition is benign and typically requires no treatment. You just have to avoid the food that is causing it. So let's say, for example, you see these three pictures in the exam. What is these three pictures telling you? Which of them needs a referral? So you need to know the one that needs a referral, which is the leukoplakia. So if you have like these three pictures, which of them looks like the one that needs referral? That is the 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 leukoplakia. So very important, very important. So always look up the pictures is really helpful. So another one is the honey crusted lesion, which we have already talked about. So we said there is one with blister and one without blister. So you look at it and see, okay, the one without blister, we said we treat it with Bactroban ointment, but the one with blister, you have to treat it with KCD, Careflex. So this is the bullous impetigo. You can see the blister, the one with blister, bullous impetigo, and the one without blister. So if it doesn't have a blister, you can just treat it with Bactroban. So sometimes you can see a diagram like this in the exam, and they ask you a question, which one needs antibiotics? Okay, which one needs antibiotics? So all this information you can always Google more and see. So which one needs antibiotics, which one doesn't? So that is it. Then we talked about the herpes one. So for the herpes, we say that is a vesicle cluster. So you can see it. So something like that, they can also ask you which one needs acyclovir. So you need to know the one that needs acyclovir, that is your herpes cluster. Sometimes it's in the mouth because we mentioned, okay, I think this is a better picture. So this is your herpes. And if you look at the definition of the herpes, we said what? Grouped vesicles, vesicles on erythematous base. So it's grouped, it's not just single. It's not just single. You can see how many is in group. Okay. Then we have talked about the impetigo. We have cellulitis. Cellulitis is high yield in the exam. So, but for cellulitis, we always have to know that cellulitis do not have well demarcated border. It does not have well demarcated border, but erysipelas have a well demarcated border. And another thing you need to remember is that erysipelas can happen, because I used to always think it just happened on the face. No, erysipelas can happen on the face. It can also happen on the lower extremities too. Okay, so these two diagram, one is cellulitis, one is erysipelas. But just know that how do we describe cellulitis? Is present as erythematous swollen skin, and cellulitis can happen at any part of the skin, any part. Okay, so but how do we um provide the treatment? How do we treat cellulitis? You can treat it using Bactrim, clindamycin, doxycycline. But remember, cellulitis does not have well demarcated border, meaning it will continue to spread. It keeps spreading, but erysipelas have a well demarcated border. So I give you another example of the two. So if you look at these two diagrams, one is cellulitis, another is erysipelas. So erysipelas can also happen in the lower extremity. You can see it's well demarcated, but cellulitis can happen and keep spreading. Another difference is that cellulitis is usually deep dermis, but erysipelas is usually superficial. Erysipelas is usually superficial. Well demarcated border, cellulitis less demarcated. Erysipelas, we said, is more superficial. Cellulitis is more deeper. It's more deeper. And what is the treatment for cellulitis? Cellulitis is always treated with Bactrim, clindamycin, doxycycline. So you questions like that you have to pay attention. If a patient is allergic to sulfur, allergy to sulfur, you cannot give them Bactrim. So because you cannot give them Bactrim, then the treatment is going to be doxycycline because they're allergic. Okay, so always know that. But erysipelas have a well demarcated border, and another important is that treatment for erysipelas is usually the same case CED, Keflex, clindamycin, dicloxacillin. If you follow my previous video, I explained it very well. Anytime you have a skin condition that is mild, that you are not worried about complication, you are going to use KCD, Keflex, clindamycin, doxycycline. But anytime you are more worried about massa, like in cellulitis, we have two types, purulent and non-purulent, or infectious and non-infectious. Those ones that is non-purulent, you can use Keflex. But when it becomes you are worried about massa, you are going to use, and this is one thing you will continue to see in practice. If I tell you how many wound culture that I complete and patient is positive for massa. So when patient is positive of massa, I have to choose between these three. I have had a situation, patient is allergic to bathroom, which is sulfur, and patient is resistant to doxycycline. The only option that was left was clindamycin. So that is why it's always important that you know other options of what you can give to a patient. We have common childhood rashes, but they are all under pediatrics. We'll still see it under pediatrics, but they are still kind of rashes too under skin. You have to learn, and all these things, especially how do you demarcate it, or how do you know which one is which one. So for example, if the patient have meso meso, you are going to remember it with three C's. Three C's. What are those three C's? Cough, congestion, conjunctivitis. So those are the three C's. Congestion, cough, congestion, cough, conjunctivitis. Okay. And another important thing is that they have what we call couplet spot in the mouth. So how do I remember this couplet spot? O in couplet spot, O in rubeola. Don't confuse rubeola with rubella. Rubella is German measles. Don't confuse the two. That is rubeola, rubella. Okay. So remember, the child is going to have cough, congestion, conjunctivitis. Okay, so this is the coupler spot. You can see those whitish patches, the coupler spot inside the mouth. All those coupler spots inside the mouth. I think this is more better. This is more better. Yeah, you can see the cup. So when you have this coupler spot, that is under measles. That is under measles. And we know that with measles, we say that patients have high fever, patients have cough, patients have conjunctivitis, and patients have a spot-like rash that covers the whole body. So this is your measles. It covers the whole body. Okay, and you, of course, you should know that this child will be vaccinated, and the only time we start MMR is only when, because it's a live vaccine. So that is what this point is saying. It's a live vaccine, and it can only be given when they are 1 year, 12 months. Okay, so remember the three: cough, conjunctivitis, congestion. Then we have another condition that we call the fifth disease. Another name for that fifth disease is your what? Is your slap cheek, the erythema infectiosum. Erythema infectiosum. So we'll still cover these things in pediatrics, but we're just talking about the diagram and just to have an idea. So with this one, we say that this child is going to present like a slap cheek, like if somebody slapped her cheek. And we say that if the mother is pregnant, give this child to another person to take care of, because this erythema infectiosum, which is the fifth disease, is known as the lacy. You can see it slap, like somebody slapped the cheek, slapped cheek appearance. Okay, and it's highly contagious. So we say that it should avoid in pregnant women because of the risk of um, miscarriage. So that is the fifth disease. Okay, fifth disease. We will still see some of this in pediatrics. That is, then there is another one. So that one is known as the erythema infectiosum infection. Uh-huh. But there is another one we call roseola. Roseola is just a rash that appears after a child had high fever. Okay, after they have high fever, the child is like high fever. It may start suddenly, and then it starts subsiding. So they have a very high fever. Okay, and after the high fever, so the name of this one is Roseola infantum, infant. After they have a high fever, the mother start noticing these rashes. So what do we say here? We tell the mother is going to go away. Just whatever you can do to keep the baby calm. So it's different from this. So we always get it confused. This one is fifth disease, roseola. The fifth disease, which is this one, the fifth disease, which is the fifth disease. Okay. Then the roseola is this one after the patient have a high fever. So that is the difference. So this one is fifth disease, and also roseola can also be, so rash appears after the fever breaks. They start having the rash. It can also be called the sixth disease. So when you hear fifth disease and you hear sixth disease, it's not the same. Fifth disease is more dangerous, but sixth disease is not dangerous. Tell the mother it will go away. Okay. Then we have another rash that is usually we call chicken pox. So where is chicken pox coming from? It can either, when somebody is younger, it's called chicken pox. When they grow older, it is called herpes zoster or shingle. So remember, for it presents as a red markers. So sometimes they call it dewdrops. Dewdrops. But how do we remember this? When can this child return back to school? They can only return back to school after the lesion have crossed over. So, but we'll still see all these childhood rashes in pediatrics. But just to have an idea, the first one is the measles, and we say that the measles is accompanied by cough, conjunctivitis, and congestion, and they have all those whitish patches inside the mouth, known as what? Coupler spot. Okay. Then we also say that we have the another childhood rash, which is the fifth disease. Okay. We have the another one, which is the fifth disease, and we say that is also known as a if the woman is pregnant, it's caused by parvovirus B19. That is very, very important. Parvovirus B19, and is also known as erythema infectiosum, very high yield. So I'm talking about this one. That is the fifth disease. I'm putting it under here. So that is your fifth disease. It's caused by parvovirus B19, erythematous infectiosum, slapped cheek. Those are the words you can use. And we say that if the child, if the parent is pregnant, give this child to another person because of the high risk of of uh, um, uh, miscarriage. Okay, so very important. So remember that, and then we say that we have the roseola, roseola infantum. So the roseola infantum is always caused by when a child have a high fever, and when the fever breaks, these rashes will appear. So always use the thermometer to remember. Always use the thermometer. You check the thermometer, and it goes within later. the rash disappears. But just to have an idea, but we'll still talk about it in pediatrics. Then we have some fungal infections. Under the fungal infections, we have the tinea corporis, which is known as ringworm. Okay, so it is the annular, which is round. So all the tinea you have to know: the tinea corporis, the tinea versicolor. Tinea versicolor is known as hypopigmented. It starts from hypopigmented and hyperpigmented, always on the chest, on the neck, and on the back. Hypopigmented, tinea versicolor. Okay, then we have the tinea pedis, the one on the feet, fungal infection on the feet. Then this patient is going to present with scaling, fissuring, and itching between the toes. Then we have the tinea curis, very high yield. So it affects the groin. So always remember the curious body, that curious part in your body. It always affects the groin. Okay, it always affects the groin. Tinea curis, tinea versicolor, tinea pedis. So for example, this will be your tinea corporis. And how do we describe this? And that is how to differentiate it from um, erythema migrae. So you see in this one, it is red rash with central clearing. But if you talk about Lyme disease, let me show you this too. Look at Lyme disease. It's not the same. In Lyme disease, this is your Lyme disease. It is red rash, central clearing, and bull's eye lesion. But this one is just red rash and central clearing. But you can see the bull eye lesion in the middle. So this is your Lyme disease. This is your tinea. That is your tinea. So it's always important to differentiate all these things. That is your tinea. That is your tinea. And we have other teneas, like I said, but you just need to. We have the teneas pedis. We have the tinea pedis. We have the tinea curis. So using the pictures is really, really good. So the tinea curis is the one that happens at the groin area. So that is your tinea curis at the groin area. It's just a diagram. It might not be like perfect, but you just have an idea of what we're talking about. Tinea curis. Then even the tinea versicolor. So if you remember the tinea versicolor, we said it usually happens it is hypopigmented. It is round. It's hypopigmented. It is round. and it's always on the shoulder, it's always on the back, and it's always on the neck. So hypopigmented, hypopigmented. So it's always in the back, neck, and also is hypopigmented. So sometimes we can differentiate this one with vitiligo. So vitiligo is also hypopigmented, but the difference is that vitiligo is irregular. Vitiligo is irregular, and not just that it's irregular, it is it can be found anywhere. Tinea versicolor is always on the neck, on the shoulder, at the back. But tinea versicolor is also another hypopigmented. But vertigo can be found in any part. You can see that picture, and it's irregular. Another important thing is that if you see the tinea with the vertigo or vertigo, I don't really think there is any much treatment for that. So, but for the tinnitus, we use our anti-fungi. So we have other skin conditions like the scabies. You must know the scabies. It can be there in your exam. And the patient presents with intense itching, pruritic, inner burrows, interphalanges. You are talking about what? Scabies. And another important thing to remember about scabies is that the treatment. So, but the honest truth is that in real life, you might not really see this picture like this inner interphalangeal or inner interdigital. Yeah, but it burrows. So this is your scabies. Okay, this is your scabies. That is your scabies. So what do we educate the patient here? They have to treat everybody in that house. They have to treat everybody in that house and everything in hot water. So hot water is important. Permethrin cream is important. That is what they use to treat everybody. Okay. We also have head lice. Head lice. So the treatment is permethrin and combing out the egg, and all the bedding must be washed. Then we have another one, enterobiasis, which is the pinworm. What you need to remember here is high yield in the exam. It also causes intense itching in the genital area. So what do we use to diagnose it? Scotch tape. We use the scotch tape. So please don't forget that, the scotch tape. So that is the pinworm, the pinworm, and they use the scotch tape. Okay. We have talked about the herpes. So this is another one. When we talked about chicken pox is for children. But I said if the person is older, what they have is herpes zoster. Herpes zoster is your when they grow older, They will always say that there is a reactivation. It might be as a result of infection, it might be as a result of stress, but there is a reactivation. So that is your herpes zoster shingles. Okay, so very important that you remember that shingles, and it's very painful. It affects adults. It's reactivation of chicken pox. So everything I said now, if you want to differentiate chicken pox and herpes zoster, that is the same thing. Chicken pox is usually affect children. It's more milder, but shingles is painful. It's caused by reactivation. It's caused by reactivation. And we know we still give them vaccination. We still give them vaccination from 50 years. So what vaccination do we give them? Shingles at 50. Please, it's very high yield. And they also need, so if they put a picture, because this picture can be found in different, you know, picture like this. This is how it looks. That is what we call, look at it, vesicular rash along a single dermatome or dermatode, whatever you call it. So typically on one side of the body. And patient is going to report burning, tingling. We have said it before the rash. So look at the diagram again. Patient is going to have vesicular rash. Anytime you hear about vesicular rash, this is high yield. This is a buzzword. Vesicular rash. Where do we have vesicular rash? It's found in chicken pox. It's found in shingles. Vesicular rash. And this herpes is on along a single dermatome or dermatode, meaning it's typically on one side of the body. When you are asked, is it on single dermatode, multiple dermatode, you know how they put all those questions. You need to know is on single, which is usually on one side. On one side, another thing that shows is there's a couple of diagrams that shows it's just on one side. I give you another example. You see, just to tell you is on one side, single dermatode. So look at this diagram now. You see is on one side. So when you see a patient have something like this side is clear, but this side have this. So that is what we mean by is a single. So it's on one side of the body. And we said is a what? Vesicular rash. So what vaccination do we give them? Shingles. So if you see a picture like this and they ask you which of the following patient will you refer? Which of the following patient will you refer? Of course, the person you are going to refer is this person because we said we are referring them to ophthalmologist. So another example too why we have to refer them. Let me show you another picture and you see is on one side still. And this is your, so the diagram is always like this. So all this is talking about the same thing. It's always like this. So it doesn't matter. Sometimes you can see it on the face, you can see it at the back, but what you need to remember is that it's a single, is a along one side. And if you have a picture like this, have other pictures we have talked about, and they ask you which of the following patient will be referred to a ophthalmologist, of course, is this patient. And because we said to prevent permanent corneal scarring or blindness. So that is your herpes zoster. Then we have another big one, which is a molluscum contagiosum. So molluscum contagiosum, how do we describe it? Is a small raised lesion. You can see that with characteristic central dimpling. So we call it a central umbilication, dome shaped. So the buzzword, anytime you hear central umbilication, umbilication, dome shape, with central umbilication, dome shape. So when you hear something like that, but we say that it's self-limiting, it can go away, but if it's found in the genital area, then abuse will be suspected. Abuse will be suspected if it's found. So you can see it's a dome-shaped umbilication. So remember, so that is it. Is small raised. You can see that it's kind of raised above the skin. So it's self-limiting. It can resolve on its own. But if it is found on the groin, sexual abuse, it should be suspected. If it's found on the genital. But how do we describe that? It is raised, it is dome shape, it's like a bump, it's raised a little bit off of the skin, and it has a central umbilication. If found in the genital, abuse is suspected. We have dermatitis. Dermatitis is usually eczema. How do we remember this dermatitis? It comes with what? With three A's. It's usually associated with three A's. What are those three A's? Atopic, which is asthma, atopic dermatitis, and allergy. Okay. Then under psoriasis, we'll still look at psoriasis. But remember, the psoriasis is a silvery scale. Okay. And it has an auspic sign. Auspic sign is that pinpoint area of bleeding. Then we have the contact dermatitis. For contact dermatitis, it requires identifying what the patient is in contact with. Like some people, they cannot wear jewelries that is not pure gold. If they wear other jewelries, they will have like burning on their neck. And people react to so many different things. So with contact dermatitis, if you are asked about like a janitor, a cleaner, so you are thinking about maybe the person came in contact with the detergent. So and when you talk about contact dermatitis, the dermatitis is at that area of that contact. So that particular area that was touched will be the area that the contact will be. So that is the dermatitis. Let's say it happens, it's just at that specific place. If it's the hand, if it's the wristwatch or whatever, just that place the person comes in contact with that with that thing that is causing the irritation. And so that is the contact dermatitis. We have rosacea and malar rash. Malar rash is seen in what? That is seen in lupus. Malar rash is seen in lupus. So don't confuse the two. Systematic lupus erythematosus. But rosacea is a type of, we call it a mild to moderate form of acne. Moderate form of acne, and the treatment is flagyl or metronidazole gel. And we say that it appears as a mild to moderate acne. So that is rosacea. It's different from malar rash. Malar rash is lupus. Rosacea is different. Okay, rosacea is different. Malar rash is different. In malar rash, it looks like a butterfly. It looks like a butterfly. So if you differentiate between the two, you see that lupus or malar rash is always caused by lupus, but rosacea is strictly on the nose, on the cheek, and on the forehead. That is rosacea, mild form of acne. Mild form of acne, and you see the patient have a flushing of the skin. Flushing of the skin. So two of them sometimes looks at like the same. It looks like the same picture. But the thing is, with lupus, of course, the person have autoimmune disorder, but not with rosacea. So that is why they look like they are the same. This is rosacea, and if we explain it, how will you differentiate the two? Somebody that have malar rash, it has to do with autoimmune disorder. Autoimmune disorder. But rosacea is mostly so. So this is malar rash, is butterfly rash. So let's see. Rosacea appears is often associated with flushing, telangiectasias, and pastels. But malar rash has the butterfly shaped distribution, like a butterfly shape. Okay, so like I said, they may look like the same, but they are not the same. One has to do with autoimmune disorder. And like we said, when you differentiate both, you see that it depends on this patient with rosacea has flushing of the face, but with malar rash, it has to do with autoimmune disorder. Another thing there is that in lupus, there may not be pustules, but in rosacea, pustules is there. And the major thing is that rosacea is strictly limited to the face. It's just the face you will have rosacea. But lupus can be found, it can be found on the nasal bridge, and it can involve other parts of the body, not just the face. It can involve other parts of the body. So we have talked about the Mongolian spot. So this is just a picture of what we went through. The Mongolian spot, which is the birthmark we talked about. Look at it here. But we said it's usually, look at it here, sorry. We said it's usually at the sacro, lumbosacral area. Then we talked about the chicken skin, which is this one. Then seborrheic keratosis, it appears to be pasted on or stuck on the skin. This one. Then we have the cafe allotted spot, which is a hypopigmented area that usually benign. So we say that the hallmark of this cafe allotted spot, this spot is usually neurofibromatosis. And another thing we said is that patients that have things that have this cafe allotted spot, that they are most they have intellectual disability. It can also be associated like intellectual ADHD and all that. So that is cafe allotted spot. Then we have some other pre-malignant and malignant. The pre-malignant is actinic keratosis. We call it the baby. So this is just dry. It's always on a sun exposed area. Okay, it's always on a sun exposed area, and we say that if you don't take care of herpes keratosis, it's going to lead to what? It's going to lead to squamous cell carcinoma. So you can see that it's usually on sun exposed area. You can see it's dry, scaly, always on sun exposed area, and the treatment is 5 fluorouracil or cryotherapy. Okay. Then we have the squamous cell. So squamous cell is, if you don't take care of the actinic keratosis, it leads to squamous cell carcinoma. So what do you need to remember in squamous cell carcinoma is it bleeds without trauma. It bleeds without trauma, and it's also on a sun exposed area. So that means if the actinic keratosis is not taken care of, it can lead to squamous cell carcinoma. So squamous cell carcinoma. Okay. I'll put this one because for squamous cell carcinoma, like you said, it can bleed without trauma. So this is your squamous cell carcinoma. So if you don't take care of actinic keratosis, it can lead to squamous cell. So it's a scaly, slow-growing lesion that appear ulcerated and bleeds easily. So whenever you hear, and because it's cancer, so you are going to hear the word nodule, nodule, hard. Okay, but the thing is that it bleeds without trauma. It bleeds without trauma. So the next one is your basal cell carcinoma. So how do we describe this basal cell carcinoma? Very simple. It has a pear shaped. It has a pear shape and with telangiectasis. What are those telangiectasis? Telangiectasis are those tiny blood vessels. Tiny blood vessels. So it is pear shaped, is shiny, is waxy, shiny, waxy, and we say that it has telangiectasis. Pear shaped, shiny, waxy. Okay. Malignant melanoma. So this is the ABCD criteria. So for this ABCD criteria, you have to know A is asymmetrical, which means is 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 uh, is on asymmetrical. It's not symmetrical. Symmetrical is that it's in both sides. So asymmetrical is in one side. So border, it has an irregular border. Color, it has different color that changes, maybe from black, blue, red, different colors. Then D is diameter, and E, we always have E. E is elevated or evolving, is changing. It can start with a small tiny dot. Before you know it, it keeps increasing in size. So that is the AB malignant melanoma ABCD of malignant melanoma. Then after that, we have what we call subinguinal melanoma. So what is that subingual melanoma? Is a black spot that is under the nail without a history of trauma. It can be malignant. This is different from subingual hematoma, the one we said that we do trephination and drain. This one has to do with is a black spot under the nail without any history of trauma, and it can be malignant. It can be malignant. So what is the treatment? The only treatment here is you have to refer them to dermatologists because you are not dermatologists. So that is subingual melanoma. Melanoma is usually what? Cancer. So always know the difference. So this is what we are talking about. We said it's a black spot. Black spot. So it's totally different from subingual hematoma. Subingual hematoma is the one that we said it has to do with trauma, and you have to make a hole and drain the blood. So when you drain the blood, we call that one trephination. That is not what you're talking about. Hematoma is different. Hematoma is blood collection. But melanoma is what? Cancer. Melanoma is cancer. It's a dark spot. And so you don't confuse both of them. One is just you make a hole, you drain it, then the other one you have to refer them. So this is your trephination. when there is blood collected as a result of trauma. But this one, there is no trauma, and that is why we said is a black spot under the nail without history of trauma. It can be a malignant melanoma and requires referral. Don't confuse it with splinter hemorrhage, which can be associated with endocarditis. So we have our pressure injuries. So you need to know the stages, but at least the stage one is non-blanchable. Buzzword: non-blanchable erythema. The skin is intact. They just treat it with a foam dressing. But in unstageable, what you have in unstageable is that you cannot see the depth of the wound. It's undetermined and is covered with eschar. So for you to see the base of the wound, you have to, it's either you debride or you use some of the products. Sometimes they use Lysanto, Medihoney, but at that point it's unstageable. We have the suppurative or hydrantine suppurative. So hydrantine suppurative is usually more common in women as a result of can be smoking, obesity, but always remember it's as a result of inflammatory condition affecting the hair follicle that is under the armpit, groin, and breast. Under the armpit, groin, and breast. Under the armpit, especially the armpit. Okay, so here is one of the ones that we also treat with KCD, Keflex clindamycin doxycycline. No, dicloxacillin, sorry. Keflex clindamycin dicloxacillin. We have folliculitis. Folliculitis is skin infection of the hair follicles, and we treat it with what? Keflex. We have talked about Pityriasis rosea, the Christmas tree pattern. Then we have our bite. So what you need to remember about the bite, spider bite, or when we talked about the tick bite, which is the Rocky Mountain spotted fever, Lyme disease. We said that the Rocky Mountain, the tick bite is caused Rickettsia rickettsii, and the one for the Lyme disease is caused by Borali bodeghefari. Then for the spider bite, patient reports being bitten the night before, but not noticing it then. The bite site becomes tender, deep, purple in color, and develops into a white halo around it. So this patient is going to present, a lot of patients have been bitten by spider. So it depends on how severe it is. But they describe it for you. So that is the spider bite. The spider bite. So how do we describe it? We said it's tender, deep purple in color, and develops. So we might not really have a good picture, but that is a bite. Brown recluse spider bite. So sometimes they don't notice it, and we say that it's painful, which is tender when you touch it, and halos around it. Then we have our anthrax. Anthrax, you can see the picture of anthrax. One thing about this picture, if you look at it, first of all, anthrax is a reportable disease. Okay, reportable disease, very high yield. And if you look at the diagram of that anthrax, it appears like a necrotic lesion. Okay, it appears like a necrotic lesion, but then you see it is black, which is mean of necrotic. It is painless. Okay, so the treatment here is usually, remember, this is our um, AC and DO, which is anthrax AC, anthrax cipro, anthrax doxy. Everybody have AC and DO. So everybody's anthrax, cipro, and doxy. So if you don't give them cipro, you give them doxy. Okay. So it's a reportable disease and with a potential bioterrorism implication. What does that mean? Bioterrorism. So bioterrorism from the word terrorist. So it refers to situation or substance that could be used to intentionally harm people, animal, or plant through biological agents. Nobody's asking you this, but I just want you to know. So that anthrax can be used as a bioterrorism implication. So these agents can be bacteria, virus, toxin, and they are considered as um, bioterrorism. So what does bioterrorism means? It means that it could be a weapon to disrupt society or achieve political reasons. So it can be used as a bioterrorism implication. So prompt identification and treatment are essential for both individuals, patients, and public. So it's a reportable disease. So we have dog bite. Dog bite. What do you need to remember about dog bite? P- People who are dog bitten are treating with augmentin. Some say augmentin, dogumentin. Another important thing is that we give them tetanus, TD, for prophylaxis, and we make sure, hopefully, that the dog was is up to date with the vaccine to prevent risk. Rabies risk. So always know treatment for dog bite is augmentin. They give them tetanus for prophylaxis, and they do not suture the wounds. Do not suture the wounds. So these are all the summary of what we went through already. In impetigo, honey crusted lesion, we said that there are two types, bullous and non-bullous. If it's bullous, which is the one with blister, it is treated with KCD, Keflex, clindamycin, dicloxacillin. If it's non-bullous, it is treated with muciprin ointment. Then we have the pityriasis rosea, Herald patch, Christmas tree pattern. is self-limiting. We have the shingle, and I say that the buzzword for shingle is vesicular rash. I keep emphasizing it along dermatomen, and I say that it shows that it happens on one side. One side. Melanoma, we have the ABCD criteria. A is asymmetrical, B is irregular border, C is color, different colors, D is diameter. It will be greater than pencil eraser. Then E is elevation. Then we have T. T is thinner infection, annular rash with central clearing, and that was our tinea corporis. We have talked about the roseola. I've talked then about the rubella. Rubella is the German measles. So rubella is the German measles. So German measles is a milder form of measles. So people always get confused. How do I know this is rubella? This is measles. German measles is known as rubella, but rubiola, rubiola is your rubiola is your okay. We have passed those ones. Is your measles. Okay. So for rubella, which is the German measles, is a mild prodromal symptoms. So it's going to be mild because it's not too severe like measles. So patient is going to have low grade fever, headache, malaise, lymphadenopathy, and they are going to have erythematous maculopapular rash beginning on the face and spreading downward. So it's just a mild form of measles. We have talked about the actinic keratosis, and I said that actinic keratosis is what? Is a mild form of squamous cell carcinoma. It's a precursor and is always a dry, rough, red to pink lesion. We have talked about it, and we said that the two treatments or the three treatment to remember: cryotherapy, 5 fluorouracil. We have talked about cafe and spot, and we said that the hallmark is neurofibromatosis. And another important thing we said is always related to um, intellectual disability. I've talked about the ABCD of malignant melanoma. Seborrheic keratosis, we talked about it. It appears to be stuck on, pasted on. When they said it's stuck on, pasted on. And we talked about basal cell carcinoma. We said that it's pearly shaped, waxy, with telangiectasis. So what do we do here? You just refer the patient. We talked about atopic dermatitis. We said it's related to three conditions, which is the allergic rhinitis, and yes, we talked about it already, and the asthma. So for psoriasis, always remember these three things in psoriasis. Is a savory scale. Savory scale. Auspic sign is that pinpoint area of bleeding. Pinpoint area of bleeding when a psoriatic lesion is removed. Then you have the Koebner phenomenon. Koebner phenomenon is when there is a new psoriatic lesion. When there is a new psoriatic lesion when where somebody have like a scab, where somebody have like a scab, somebody have like a trauma, a new psoriatic lesion. That is Coburno phenomenon. So know these three things. Psoriasis, okay? It presents with silvery plague, auspic sign, which is that pinpoint area of bleeding. And another thing that you need to know in psoriasis is the pitching of the nail. Pitching of the nail. Then we have contact dermatitis. We have talked about it. Contact dermatitis is always linear, localized. So it happens at that area that that exposure was done. Contact dermatitis. Shingles has to do with herpes zoster. What is the prevention for shingles? We said the vaccination is Shingrix, and Shingrix we give it from the age of 50, and we also give them acyclovir, and you have to refer them to the dermatologist, to the ophthalmologist. We have the scabies. We talked about scabies. We say that is they have intense puretic lesion, linear burrows, interphalanges, interdigital. The treatment is permethrin 5% cream. And scabies is caused by what? It's caused by Sarcopet scabi. Sarcopet scabi. Okay. So we have talked about this one already, chicken pox, and we said that they can only return back to school when all the lesions have crossed over. And also they can get the live vaccine when they have turned 1 year old. You talked about the head lice, the molluscum contagiosum, which is the dome shaped with central implication when it found in the genital abuse. Then we talked about the fifth disease. We say that it's caused by parvo B19. It appears with a slap cheek. Then we have the tinea capitis pedis, tinea barber, tinea versicolor, tinea curis. So we have talked about this. So please take time again to watch the videos again, and thank you for listening.